Hi, this is Dr. Rutherford, and we are now down to what I believe is the last in the series of functional medicine back to basics that we started several months ago. And thank you for all of your kind words, and thank you. And I'm glad for those of you who say that you're getting help from this, and that it's really pretty cool. It really makes me get up in the morning and do this. So. Female hormones. Why is this the last in the series? This is the last in the series because, as my mentors would say, everything flows downstream to the female hormones. The female hormones are affected by everything, particularly if you're still menstruating. And to a degree, even if you're in menopause, and I'm going to talk about both of those. So let's just first talk about and female hormones and like the natural cycle of what a female hormone should look like. So the natural cycle of a female hormone is, I'm going to start with the brain, and there's a structure in your brain called the hypothalamus. What you need to know about the hypothalamus is it's this little organ in the brain. It's not an organ, but it's it's an organ in the brain that senses all of the balances of chemicals, particularly hormones in your system, in your bloodstream. And so it senses how much estrogen that a woman has, okay? And then if there's not enough estrogen there, then being produced by the ovaries, then your hypothalamus talks to another organ that's called your pituitary gland. Many of you may be familiar with it, that it's called the master gland, because it sends signals to it pretty much controls all the hormones. It sends signals to the thyroid, it sends signals out for you to make growth hormone, it sends signals out for you to make estrogen, testosterone. It's the master gland. So when it is told that you do not have enough estrogen, it then tells your ovaries to make estrogen, okay? But that's not the end of it. The estrogen then has to be made, and it has to go out to the cells that need it. And in women, that's certainly it goes into your brain. It gives you better mood. Estrogen certainly controls how your ovaries work, and so there's a lot of feedback in there relative to menstrual periods and having them, and along with progesterone having proper cycles, and so and then estrogen in women. The next step would be, once it hits all of the cells, the frontal lobe cells, and it gives you good mood and it just ultimately has to be cleared after it goes to all the cells. So it goes to these cells, and then and so the estrogen goes to the cell. This is a cell. It hits the cell opens, it goes in there, the cell uses it. When it uses it, it has mechanisms to detox itself, to send the unused estrogen and the kind of used estrogen now has to be cleared from your body. This is a very, very, very important salient point. So when it gets cleared, it gets cleared like anything else. There's a certain pathway in your liver that clears your estrogen. Then it has to be cleared through your gallbladder, because gallbladder takes all of the toxins. There's bile formed, the gallbladder spits it out into your intestines. It has to be cleared through your intestines. There is a enzyme in your intestines called beta-glucuronidase that actually further clears your estrogens. If that enzyme is too high, it'll actually reconstitute estrogens and make inactive estrogen into active estrogen that was supposed to go into the toilet. The inactive was supposed to go into the toilet. We'll talk about that in a few minutes. So and then it can go, and then it also can be, estrogen can also be stored in your fat cells. So women are estrogenic, and it's natural for women to have estrogen in their fat cells. There's this kind of cool little mechanism in there that if a woman starts getting too much testosterone, first, before they develop polycystic ovarian syndrome, which is caused, has too much testosterone as a feature, it'll get stored in your fat cells, in your adipose tissue. And so this is the cycle of estrogen, and you have to kind of remember that as I'm walking through this. So, so things that affect any of those processes are going to alter your estrogen function. So I think today, I guess the next step to go to is today, most people who come in here with female hormonal problems aren't coming in here expecting that I'm going to talk to them about their liver or talking to them about their intestinal dysfunction or talking to them about blood sugar or essential fatty acids or all of the things, or their stress, are all of the things that ultimately go into making your hormones. They're not usually expecting me to talk to them about their cholesterol. And this is a point that I don't see made enough. Today we are subject to whoever makes these decisions that are making this decision that our cholesterol should be down below 150 or 100. And that's incorrect based on the understanding of physiology, because when your cholesterol starts getting down that low, and this happens in a lot of thin patients, when it gets down that low and your doctor's telling you how great it is, it's pretty well understood that below 150 in cholesterol, it's difficult to make hormones. Almost all of our hormones are made out of cholesterol. Almost all of our hormones made out of something called cholesterol and pregnenolone, and so these are all things that in the functional world we look at. If a person's coming in here with scanty blood flow, excessive blood flow, they're coming in here with periods that are all over the place, they're coming in here with facial hair and acne, and we might be looking at, and we're going to talk about polycystic ovarian syndrome in a separate video, so it's not technically going to be part of this series, but we're going to talk about that. And actually, we have videos online already on polycystic ovarian syndrome if you want to look those up. So we could be talking about polycystic ovarian syndrome there, which also has a lot to do with all of these imbalances in all these organs that I talked about. But we're going to be looking first at all of those things because all of them play a role in, particularly in the menstruating female, all of those play a role in making your estrogen balanced. So let's say you're not eating enough cholesterol. Maybe you went on one of these like low fat diets, and maybe you really got a lot of low fat, and all of a sudden you start getting all these symptoms. It's like, what is going on here? And you go, and they take your estrogen, and your estrogen is low. They give you hormone replacement therapy. Let's say that your intestines has too much of this enzyme that I briefly mentioned called beta-glucuronidase. Beta-glucuronidase will cause the estrogen that is supposed to have been detoxified and then going into the toilet, because remember, your brain knows how much estrogen you need, But if this beta-glucuronidase is too high because of a number of things that could be going wrong with your intestines, irritable bowel syndrome, SIBO, any of the autoimmune diseases like celiac or Crohn's or anything like that, you're going to reconstitute your estrogen before it goes into the toilet, and it's going to be reabsorbed, and you're going to be estrogenic. You're going to have too much estrogen. Too much estrogen, by the way, creates the same symptoms frequently as too little estrogen. And the reason is because if you take hormone replacement therapy and you have, again, in the cycle of what the hormone's supposed to do, it's supposed to be made and then it's supposed to be used. By it being used, the hormone actually gets on this little protein, it gets over here to the cell, and then there's an enzyme that cleaves that off, and then the cell goes, whoop, opens up, and it goes in. But if you give yourself too much estrogen, like from creams and stuff, then that estrogen will cause this to become resistant, this receptor site. It'll go like, I've got enough, and eventually this receptor site just won't open. If it doesn't open and estrogen's not getting in, you're going from you, and they take a lab of your estrogen. They're going like, well, your estrogen's like 900. You have like too much of it, and you're getting like low estrogen symptoms. This is why, and it's fairly common. If somebody comes in, and I'll put this in line with what we're talking about, if we're looking at their intestines for the beta-glucuronidase, if someone comes in here on what we call post-birth control syndrome, someone comes in here, they want to have a baby, they've been taking birth control pills for 10 years, we have to take 3 months to clear all of the estrogen out of their system so that we can get a proper feedback loop going between their brain and their ovaries so that we can now give them the proper supplements. In fact, when we do that, and we work with their intestines, we work with their liver, we work with their gallbladder, a lot of times I would say 70% of the time the person's hormonal balances start to level out. We just ran kind of a little beta test on a program that we're thinking of putting out here in the next few weeks. And it's really, for lack of a better term, it's a detoxification program. It's a strip all the inflammation program out. It's fairly genetic, but we kind of tailor it. We have ways of tailoring it to that individual person. And we have one of the gals here, and she said it's okay for me to say this, although I'm not going to say her name or anything. We put her on this protocol, and she hadn't had a period in 2.5 years, and like within a couple of weeks, she started having her periods again, just by clearing out the estrogen, just by getting her liver working, and so on and so forth. So let's go back to let's go back to that. I hope I'm making sense here. So let's go back to estrogen is at the bottom of like the stream, and everything else affects your estrogen. So if your liver's not clearing and your gallbladder's not clearing, then you're not clearing the estrogen. Now you get too high estrogen, right, in your system because it's not getting cleared out. Now that too high estrogen maybe starts giving you symptoms, or maybe that too high estrogen starts shutting down your receptor sites, and the next thing you know, you got signs of too low estrogen, but you got too high estrogen. But they go in there and they go, here, take hormone replacement therapy. But my estrogen's high. This is the tool in the medical community, is to take the hormone replacement therapy, period. First, last, and always. And when you take that hormone replacement therapy, it tells your brain you have enough estrogen. That brain then tells your ovaries that they can kick back, that they don't need to make estrogen, and then the ovaries start to atrophy. Next thing you know, you lose that feedback loop between your brain and your ovaries. And if you're younger, if you're a menstruating female, that's enough that could make you not be able to have children. But the point is that there is that feedback loop. So your ovaries could start to atrophy. Your pituitary gland could start to not make luteinizing hormone or follicle stimulating hormone, particularly luteinizing hormone in a female. Your hypothalamus is fine because it's just saying, oh, we got a lot of estrogen in here. Pituitary gland, take a break. take a break, take a rest, go to the beach, have a few martinis. You don't ever have to work again because somebody else is doing your job for you. Somebody's telling the ovaries to put estrogen here, but it's not telling the ovaries. And the ovaries are doing the same thing. They're going like, wow, nobody's talking to me. So the ovaries start to atrophy. They go on vacation too. This is the downside of hormone replacement therapy. I'm not 100% against it, but I'm only for hormone replacement therapy in certain occasions. So I don't really even run, most of the time I don't really run female labs. When somebody comes in here and they have all these female, and they have all the symptoms, the scanty blood flow, the heavy blood flow, abnormal periods, just all of the premenstrual syndrome. Most of the time, I don't even run female labs when they first come in because I'm going to be looking at their liver. If their liver's gunking up, they're going to have too much estrogen in their system. I'm going to look at their gallbladder. If their gallbladder's not working, they're going to have too much estrogen in their system. If I'm going to be looking at their intestines, I'm going to be looking at blood sugar. Blood sugar has an awful lot to do with the manufacture of estrogen down the road. I'm going to be looking at adrenals, stress hormones. Your secondary sex glands are your adrenals. And your adrenals and your blood sugar work together. You can look at that segment. And when adrenals go up, then blood sugar goes up. When adrenal goes down, blood sugar goes down. When your blood sugar is high and low, it affects these things called sex hormone binding globulins. These are the things that carry your estrogen all over the place. And so when you're stressed and your adrenals are flaring off and it's causing your blood sugar to be high, it screws with these little taxi cabs, these sex hormone binding globulins. Now all of a sudden you're not getting estrogen to where you're supposed to be, and it shows up as low estrogen. And it's actually that you're stressed. That's affecting your adrenals. That's affecting your blood sugar, and all of that is affecting your female hormone cycles. So again, this is the functional approach. And essential fatty acids are important. I will usually in the beginning do a lab on someone who has these problems to determine if they have enough essential fatty acids in their body, because essential fatty acids under normal circumstances sensitize these receptor sites to make them work better so that they don't get stuck and so that the hormone can get in there. So I don't really do testing in the beginning because I'm going to treat all of the other aspects of what that person presents with, and their labs are going to look much different later on than they would look in the beginning. Well, I don't really need to know what they look like in the beginning because now if we do all of that and the person's still having imbalances in their female hormone health, okay, then you run the labs, because at that point you run the whole lab from the brain. You run the follicle stimulating hormone, you run all of the estrogens. I run DHEA and I run DHA sulfate. I know your endocrinologist would say that that's like stupid. It's not, and because it tells us what your adrenals are doing, and your adrenals are a part of your female stuff. I run a thyroid lab because thyroid helps it helps to sensitize your receptor sites so that your estrogen works properly. So I run a thyroid lab, and I run obviously testosterone and progesterone. So I run the whole lab to cover that whole feedback loop to see if it's even working. And if this part's not working, the luteinizing hormone is follicle stimulating hormone coming out of your pituitary. There's herbs and botanicals for that. If the ovaries aren't working and they haven't atrophied yet, which you can pretty much tell from the labs, there's powerful herbs to balance that out. There's herbs that actually will balance that out. If you have high testosterone, bring it down. If you have low estrogen, high estrogen will bring it down. Low estrogen will bring it up. And even progesterone. If a person's not, person's losing their egg, if they're got pregnant and can't carry the term, there's herbs and botanicals for that. So the next step would be to use those herbs and botanicals based on the labs. And then if all fails, then I think hormone replacement therapy probably is something that needs to be done. I'm going to tell you, if you follow that whole thing, it rarely fails. I mean, it's your physiology. It has to work. You just have to figure out what it is that you have to do. Perimenopausal women, so a few things I want to mention. Let's go to menopausal women, then I'll go back to that. So menopause. When you go into menopause, okay, whether it's because you've turned 50 and you're going into menopause, or whether it's because you've had a hysterectomy and they've taken everything out, if you know what's going on, you rarely ever need to do hormone replacement therapy. And I know that for those of you who've had your ovaries out and your uterus is out, you probably think I just lost my mind, but hear me on this, okay? You basically have been put into menopause if you're younger and you've had it taken out. You're not gonna have babies, you're not gonna cycle anymore, you don't need a lot of estrogen. And what happens when that happens, and what happens when you've crossed the bridge into menopause, is your adrenals take over responsibility. The baton is handed to the adrenals, takes over your responsibility for managing your sex hormones. Your adrenals make estrogen, testosterone, and progesterone, and so they don't make anywhere near as much, but you don't need as much. Because again, you're not cycling. You're not going through that whole stress on your system. You're not going to have a baby. You don't need as much estrogen. You need estrogen, and you need enough estrogen, but nowhere near as much. And so if it's the adrenals, then you're looking to, if the baton has been passed the adrenals, in those cases, you're looking at the adrenals. Frankly, you're looking at the adrenals and the blood sugar, because again, adrenals and blood sugar kind of track together. So you're looking at, and adrenals are affected by everything. If you have an infection in your body, it affects your adrenals. If you're stressed, it affects your adrenals. If you have small intestinal bacterial overgrowth, it affects your adrenals. Everything affects your adrenals. So again, you go back to same thing. You're still going to go back to liver, gallbladder, essential fatty acids, blood sugar, adrenals. Except this time, the adrenals are more prominent. Do I start going in there and throwing adrenal supplements at people right away? No. I would see if they're stressed. If they're really stressed, I might use some, I do functional neurology too, so I might use some brain rehabilitative neuroplasticity exercises. But there's a lot of herbs and botanicals that can be used for stress. And if they're not strong enough, then maybe the person needs to take a medication for that. But because of stress, hormones are now much more prominent even in menopause, because the adrenals are the guys, and the adrenals are the glands that put out all the stress hormones. So stress, adrenals, all those other things, and the vast majority of the time, if the person has not been on hormone therapy for a long time, and the adrenal and that aspect of their adrenals stops making even the little bit of estrogen that it makes that the person needs, then they'll need hormone replacement therapy. One point I want to make on this is I get a lot of women that come in here and they're like late 30s, early 40s, and they're having the hot flashes, and the doctor's like, you're in early menopause. You know, I've studied with some pretty profoundly brilliant people. These are people who are in practice. These are people who do research. These are some of them specialize in female issues, and they will tell you, and I think they are correct, is that these women are not in early menopause. They're having more significant problems with all of the aspects of the things that I just got done talking about, the liver, the gallbladder, that most of the time the intestines are involved. Maybe they're going through an incredibly stressful period. Maybe they're trying to do too many things, and maybe they're trying to be a mom, and and working and taking care of a husband and taking care of kids and all that type of stuff. And it's just hammering their adrenal glands, which in turn is hammering their blood sugar, which in turn is hammering their intestines and their liver. So the vast majority of the time, that's what it is. And you can run a panel on a postmenopausal on a menopausal female and see what that is. Now, in the last bit of pieces here is in the adrenal glands. There's this unique setup where your adrenal glands are your fight-flight glands. So if your brain goes into fear and fight-flight, your brain tells your adrenals to start putting out stress hormones to put you in shape to fight or flee. Here's the problem. The adrenal glands are your secondary sex glands, right? They make they actually, even in a female, they make testosterone first. And then without getting through the whole chemical thing, the testosterone eventually is involved with making estrogen, and then that's eventually involved with making progesterone. Like that, almost like you pour the cup in, you get enough testosterone. Next thing you know, it starts making estrogen. Next thing you know, it starts making that. Here's the problem. In the adrenal glands alone, especially if you're in menopause and it is your source for taking care of you, as far as getting you enough estrogen, when you get stressed and you're making cortisol, you can't make this stuff called DHEA. DHEA is what makes the testosterone, that makes the estrogen, that makes the other stuff. And DHEA is a hormone that's made from cholesterol and pregnenolone. So there's this thing in your adrenals called a pregnenolone steal. And what that means is you're either making sex hormones or you're making stress hormones. You're stealing the pregnenolone to make stress hormones because pregnenolone also goes to make your stress hormone cortisol. So stress is a huge, huge part of so many of these female issues that it's crazy. That even in the menstruating female, where the adrenals are not the main guys, they're like the secondary sex glands. Stress is a big player. Stress is a big player in this. So I think, yeah, and one other. So you look at all those things, and the other thing that you would look at, the other thing that we would look at, relative to particularly the menstruating female is, well, I should probably save this for the PCOS, but overtraining. Overtraining creates a lot. I'm seeing more and more women who are doing CrossFit and they're competing and they're doing, of course, this has been for a while now, and are doing triathlons and marathons and just all that type of stuff. And there's a balance to training. And when women start training like that, that will start creating hot flashes because their estrogen will go low. They have a hard time having babies if they're a female age because their testosterone goes up, their estrogen goes up. I said that because I hesitated on that because it's also kind of part of the polycystic ovarian syndrome, I can't have a baby syndrome. But relative to menstrual issues, it's pretty well understood that if a person is going through that, it's not uncommon to have abnormal periods or like not have a period. So that was kind of like one other clinical pearl that I just wanted to throw in there. So that's kind of the lay of the land of female hormones. I think what I wanted to do was more make you understand kind of the options that you would have when you start having these issues, or if you're taking the hormone replacement therapy and you're not getting better, or you're concerned about the possibilities of too much or it making cancer. Remember, if you take too many hormones, it's just like not taking enough. You cause those receptor sites to become resistant, the hormone doesn't get in, and now you're taking hormones and you have all these symptoms of low hormone function, and you're going like, what the heck is going on? And your doctor's going, well, we'll just give you a little bit more estrogen because they haven't run all of the panels. This is what you're facing. So I think that's it. I think I want to wrap it up with that. I think that's a good, again, I'm speaking from the clinical perspective here of of my thought process when a patient comes into me with these symptoms. And so it was it wasn't my thought to get into like all of the different aspects and all the different herbs and botanicals and all that, but more to point out that the physiology of it. And as I'm saying that, I think of one more thing. If you have hot flashes, ask yourself, are you sweating? Or are you just sweating, or are you hot? Are you having a hot flash? Because that's another thing I run into. And if it's just sweating, it's your adrenal glands. It's not a hot flash. And so what's the target? The target's the adrenal glands, and anything that would be fixing the adrenal glands. Almost forgot that. So I feel like this is a good summation. I feel like this gives you a good framework. A lot of people today, of course, are looking online. That's why I'm doing this. So a lot of people, by the time they've gotten here, they've looked online, they've tried to figure this out, they couldn't, and if they couldn't figure it out, a lot of times they just show up here or at some functional medical doctor's offices. So that's female hormone imbalances. And I think that I think it lights a lot of people up. I think a lot of people kind of go like, ooh, holy cow, I never realized all that. If you did that, good. That's why we're doing these online YouTube videos. So, okay. So that's the end. I think that's the end of this that's the end of this presentation. For those of you who don't know what I'm talking about, that's the end of our entire series. And I will be looking forward to hearing feedback from you on this particular subject, because it's a subject I have great interest in, and I'd like to know what your thoughts were on this. So I'm Dr. Martin Rutherford. That is the end of the Functional Medicine Back to Basics series. I hope you enjoyed that, if you managed to get through all of those. And thank you for watching. Take care.